Hey, gang. Welcome to the most wonderful time of the year. It's not Christmas. It's even better. Deer season opens tomorrow. So this week, what we're going to be talking about is heart health, heart physiology, and really how training and exercise can help benefit heart health. In order to really discuss too much about heart health, what we need to do is we need to talk about what is the heart, cover some basic heart physiology, and then we can start getting into some of the training periodization type stuff, right? So most of you guys have not had anatomy and physiology yet, so I want to go over what is anatomical position. So what I want you to do is imagine that you're looking at someone, such as this joker right here. Their palms are going to be facing towards you, and their right side is going to be on their anatomical right, and their left side is going to be on their anatomical left. So what that means is that as you're looking at an individual face to face, anatomical right would actually be what would appear to be their left side to you, and their right side would be their anatomical left. So I know that sounds super confusing, and there's not really a great way to explain it other than because this is his right arm, technically, this is going to be his anatomical right side. Because this is this man's left arm, it's going to be his anatomical left. And that's important because when it comes to the heart actually sits on this axis of deviation, right? So the heart does not, in most individuals, unless you're really tall, the heart does not sit perfectly vertical. It actually ends up being kicked off to the side so that this area called the apex of the heart is actually going to be tilted somewhat. And it's going to be tilted favoring to the left-hand side. This axis of deviation can actually be manipulated based on the height of an individual. So the shorter an individual is, the more likely that's going to be a greater and greater axis of deviation. The taller the individual is, the less likely it's going to be deviated, and it might start going almost vertical. So what makes up the right side and the left side of the heart, and why do we care? Well, the right side, again, is going to be anatomical right. The right side is going to be comprised of a right atria and a right ventricle. So the atria are going to be sitting on the top. These are both atria. And then the ventricles are going to be sitting on the bottom, such as here. The left side is going to be the exact same thing. There's an atria that's sitting underneath these pulmonary trunks and aortas, and there's also a left ventricle that is sitting down here as well. Getting more into some of the anatomy of the heart, you can see that, again, we have the right atria and the right ventricle, the left atria and the left ventricle. And what you can see is that there's actually quite a bit more musculature around the bottom or around the ventricles than there is around the atria. And that makes sense because essentially what happens when you're using the heart as a pump is you have these atria that are serving almost like passive blood holders, if you will. So the blood will actually come in either from the lungs for the left-hand side or from the periphery, the rest of the body, to the right-hand side. There'll be a passive filling that occurs, and then that passive filling will get beat into the ventricles. The ventricles will contract and expel blood out. So what we're doing with the heart is literally functioning it as a pump, right? I know a lot of you guys know this, but really the heart is a mechanical working device. It is a pump that is designed to move and facilitate blood flow throughout the body. That's why it has rhythmicity to it, and that's why it makes sure that it continues to work. And if we don't have it, then it's not good for the human and we die, right? So the right-hand side is predominantly going to be focused on deoxygenated blood. And what that means is that it is blood that has already been used by the body, and it's blood that still has to go to the lungs in order to get oxygenated. So what you have here is you have the superior vena cava, the inferior vena cava, which just means that it's a venous system, and they're coming into the right atria. You're going to have the pulmonary trunk, which is this right here, and then the pulmonary arteries, which are these guys right here. And if you look, you can see where it kind of says to left lung. It's supposed to say to left lung. And that's why this side over here says to right lung. So this pulmonary artery is actually going to be carrying blood that is deoxygenated away from the body. Whereas if we go all the way back around, we can pump blood from the heart to the lungs. Let's imagine that the lungs are over here to the right-hand side of the screen. You're going to oxygenate the blood and you're going to bring it back in to the heart, right? We're going to actually pump blood towards the heart from the lungs, and that blood is going to fill the left atria passively. That blood is going to pass in to the left ventricle and then be pumped out of the aorta and into the rest of the arteries in the system. So something that I want you guys to think about is that arteries are responsible for carrying blood away from the heart, and veins are responsible for carrying blood toward the heart. Oftentimes you'll hear people say that arteries carry oxygen-rich blood and veins carry oxygen-poor blood. That's not true. It's not true at all, actually, because immediately outside of the heart, you're going to be using the pulmonary artery to shift blood to the lungs, and you're going to be using pulmonary veins to bring blood that's oxygenated back into the heart. And if you look, you can also see that there's arrows designating the blood flow path through the heart. And you can see that there's not ever really a mixing of deoxygenated and oxygenated blood. And that's exactly what we want. We want to make sure that we keep those two things separate. If we know that the heart is functioning as a pump, then we should be able to have a rate, or we should be able to have a beating of that heart, because it has to mechanically squeeze in order to put blood throughout the body. And that's exactly what your heart rate is. So I'm sure at some point in your life you've taken your heart rate, whether it was at your carotid or it was at your radial. You can also take it in your brachial artery, which is right here in between your bicep and your humerus. So what we're going to do is we're going to actually go ahead and take our heart rate. So what I want you to do as you're sitting there is I want you to take your first two fingers and then find the spot just kind of south of your thumb, right off towards the radius. So it'll be in this general area. And I want you to sit there and I want you to count how many times you feel it pulse through there in 15 seconds. Ready? Go. Awesome. So I want you to take that number and multiply it by 4. And the reason that you're going to multiply it by 4 is because we're trying to find the average number of beats per minute. So 15 times 4 would be 60. 60 seconds makes a minute. So if we multiply the number that we counted in 15 seconds, then we know about how many times our heart's going to beat per minute. You can manipulate this number by just changing the time domain for which you've been counting. The more accurate one is going to be to go for the entire 60 seconds, just counting continuously, but you might get bored. I don't know. At least I do. I'm kind of like squirrel. We've covered some basic anatomy. We understand that the heart is functioning as a pump, but how does the heart function as a pump? It doesn't make sense, right? It's a weird contraction. It's a weird movement. So one of the coolest things that you guys are going to learn as you're going throughout your kinesiology career, your kinesiology major here at University of North Georgia, is that while our bodies are basically big bags of water a lot of times, we're also really good at conducting electricity. And so the way that our brain works is actually it signals with electricity inside of your brain to create thought, to create consciousness, to create all those things. Our muscles work on a very similar manner. We actually send signal from our brain down our spinal cord and into our muscles via electricity. So if you look up here on the top right-hand side, you can see everything that is yellow is actually being read as essentially electricity. And again, you can see that we're on the right-hand side of the heart here and the left-hand side of the heart over here, making this the superior vena cava, inferior vena cava, right atria, right ventricle, pulmonary trunk. So what you have up here is this first little dot is called the sinoatrial node, or the SA node for short. This SA node is a small collection of muscle cells inside of the heart that actually have inherent conductivity to them. They have an automaticity to them that means that they are going to fire off an electrical signal at a specific time within a specific time domain always. And what you have down here is something called the AV node, or the atrioventricle node. And so it's a similar concept that sits right between the atria and the ventricles, hence the name, right? So what happens is you actually send a signal, an electrical signal, through the atria, and you can see that it's traveling across to the other atria here. And when that signal is sent, the atria contract, right? So every time our muscles get hit by electricity, they're going to contract. Same thing down here. As soon as you see the AV node hit and then fire electricity all the way through those ventricles, it causes a squeezing of the ventricles to force blood flow out of the ventricles. And what's really cool is the direction in which the electricity runs is going to be what's actually driving the blood flow up and out against gravity. So if you look, the electrical current will jump across into this system, which is called the Purkinje fibers, and out and across the heart. And what you can see is that as this electricity goes down, it's forcing the blood to be squeezed up and out because it's contracting down and then up, right? Like we're sending a signal, so we're actually forcing all that blood to go up and out. This is exactly what you're reading on an EKG. How many of you guys have ever been in the hospital or been with a family member, a friend that's had an EKG placed on them? Literally what you're doing is you're reading the electrical signal. You're reading the depolarizations occurring within the heart so that you can have an idea about the general heart health. And so what you have is you have this concept of a P wave, a QRS waveform, and then a T wave. And so what the P wave represents is atrial depolarization, or atrial contraction. So if you look, you can see as soon as this turns green, the atria are contracting. The atria are squeezing down. That's that top section. The QRS, because it's a lot bigger section of muscle and it's a lot more active, has got a lot bigger of a peak. It's got a lot bigger of a peak, and you can see that when the QRS turns green, you actually have ventricular depolarization and you have a squeezing of the bottom half of the heart, forcing blood up and out. And then the T wave is actually a relaxation. So it's when the heart relaxes, returns back to normal so that it can stretch again and then contract again. Stretch again and then contract again. Think of it like filling up a water balloon. One of the cool things about EKGs is that you can rapidly deduce heart rate off of it based on the number of peaks that occur within a specific time domain. Rather than dive into how you analyze EKGs, I just want you guys to see what the difference in electrical signaling is for different types of heart rates. So if we just went over the fact that every time you see one of these P waves and a QRS, it means that it's the heart contracting. So here you can see beep, 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 right? Or better said, beat, beat, beat. If we speed that up a little bit, beat, 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 right? It's a little bit faster. 75 beats per minute, 100 beats per minute, 150 beats per minute, and then 300 beats per minute. So you can actually see the heart rate in live time by using an EKG. And that's different than using a pulse, because when you're checking a pulse or you're checking a heart rate through pulse, what you're actually doing is trying to track a delay to see if there's essentially you can't feel this change in pulse until that signal and that blood has made it from your heart, squeezed up all the way down your arms and reached that point. The concept is that it should be normal. It's not always the case. So if we're continuing down this stream of heart rate, and we know that heart is a pump, and the heart pumps blood that contains oxygen or oxygen rich or oxygen poor blood, we can probably go ahead and start figuring out that with exercise, we're going to have changes in heart rate, right? We're going to need different levels of oxygen to our muscles, to our body during different stages of exercise. And our heart is actually going to be the thing that controls the pace at which our blood gets delivered to our working muscles. So the harder you're working, the more intense of a workout it is, the higher your heart rate is going to go. Now, there's this concept of a theoretical maximum heart rate. And it's not necessarily the most accurate thing in the world. Some people can go above it, some people can go below it. But essentially, your maximum heart rate, quote unquote, is going to be 220 beats per minute minus your age, which is equal to your theoretical or hypothetical maximum heart rate. This is an indirect way of measuring this, and it's a way of guessing what an individual's heart rate is without having to really analyze it in live time. So, in order to calculate a target heart rate for an exercise bout so that we can actually start prescribing exercise so that we can know how hard an individual is working, we're going to use Carvonin formula most often. And what that is first you have to calculate your heart rate reserve. So in order to calculate your heart rate reserve, you calculate the potential or the hypothetical maximum heart rate, so 220 minus your age. You then subtract what your resting heart rate is, what that first number that we calculated today was, and that's your heart rate reserve. In order to then calculate the target heart rate or the heart rate zones, you then do your heart rate reserve times what intensity you want an individual training at, like 0% to 100%, and then add back in the resting heart rate. So the concept is this is going to give you an individualized number for every single patient, client, whatever that you're working with, so that theoretically you could be applying a similar stimulus to individuals of either different sizes, different body weights, different training statuses, different fitness levels, all of that. And you can apply a more specific training program to help better the athlete or better the individual. And this is how we generate our heart rate zones. So how many of you guys actually have like a Garmin, or you use a GPS watch, or you use your phone to track your heart rate whenever you're exercising? Or even better, you've probably walked or ran on a treadmill at the gym where you have to like hold on to these electrodes and then it'll tell you what zone you're in. Well, essentially those zones are using your potential heart rate, or your heart rate, your target heart rate, if you will. The lower your heart rate is, the less stressed your system is going to be, the more likely your system is going to be relying on 100% fat or more and more fat for energy. That is beyond the scope of right now. Don't stress over it too much. But what I want you to really pay attention to is this left-hand side and this far right-hand side. So you can see that as you increase in zones, you actually increase in percent intensity, if you will, or how hard an individual is working out based on their heart rate. And then based upon what zone you're training in, you're going to get differing training benefits. So whereas zone 1 might be recovery, real low level basic fitness, zone 5 is going to be 100% all out training hard as you possibly can at that specific moment. Time frame that you're going to be able to train that is very, very small. And it's going to be focused more on building your power.